So my research is generally on impacts of healthcare information systems on care, costs, and quality. And I approach this topic from different angles. So one of the topics that I'm particularly interested in this domain is network externalities driven by health IT. So this is because the technology adoption decision is done at the focal organization level, and naturally that's where most of the literature and the projects are focused on. But the impacts of these technologies can go beyond the adopting organization, because often healthcare providers need to exchange data with each other as patients move across different providers. So we study the implications of this patient and information sharing on healthcare costs and quality and care outcomes for patients. One important aspect of health IT and electronic health records is that they can implement digital protocols and standardize care procedures, which becomes especially important for situations where decision-making is more complicated than complex, and we observe a huge variance in terms of the outcomes and the cost of care. So here we study how electronic health records and these types of digital protocols can impact the way physicians make decisions and eventually the patient outcomes and care costs. Electronic health records, they also change the way physicians interact with patients and how patient data is captured and recorded in the first place. And this has important implications for billing, reporting, insurance claims processing for healthcare providers. And this has down the line implications for healthcare auditing and potential fraud that goes through this insurance claims processing. And today I will present a paper within this domain. And as I will explain when I go into this part, right, the insurance claims processing is a very information intensive task where the providers need to meet complex requirements of various insurers. So as far as the current, the future projects that we're thinking about, we are currently working on hopefully putting together a series of projects of using AI and machine learning in this process, because it's very information intensive and highly documentation based. So this is a perfect candidate for using artificial intelligence to improve insurance claims processing, auditing, and all the past data that is now available can be used to understand better finding patterns for fraud detection. So we have done some work here in the Car Lab on data visualization in different healthcare processes. So we also think that this will help us for putting together a series of projects on how we can leverage artificial intelligence in this healthcare claims and audit process. We also have some projects going on health IT security and data breaches for hospitals, and healthcare sector is actually the sector that suffers most from data breaches and external attacks. And of course, right, many of the presenters have talked about importance of ESG. It's an important topic for a lot of different industries. We're also exploring the implications of ESG in healthcare. So this is just a brief overview of the healthcare research that we do here in the Car Lab. And let me actually go into the details of this paper that I will talk about today. This is about the relationship between health IT and insurance claim denials. And Jonas talked about, right, the importance of interoperability, data standards in the information exchange. So this is in a way actually looking at this interoperability issue of different health IT applications in the healthcare context. And let me start with uncompensated care, which is actually a huge part of overall high healthcare costs in the United States. So uncompensated care has been prevalent, and within the last couple of decades, it adds up to be over $700 billion. For the more recent years, averaging about $8 million per hospitals. And a significant part of uncompensated care is coming from claim denials. So these are insurance claims that are submitted by healthcare providers to the insurance providers with the expectation of getting paid. Some of them are denied initially, and some of them remain unpaid eventually. And this is a significant challenge for healthcare providers. For example, in 2016, around 9% of all hospital charges were initially denied, which is putting about 3% of net patient revenue at risk for these organizations. And again, in terms of dollar values, they add up to a significant chunk, so averaging about to be $3.5 million per hospital. So why claims are denied? So they can be denied due to errors. So these errors could be technical errors, demographic errors, but there are also all other host of issues that can happen. There can be authorization problems, eligibility problems, medical necessity problems. And there are also ever-changing complex payment requirements that the providers need to be aware of and comply with in this process, making this overall a quite challenging process for healthcare providers. So what happens if a claim is denied? Well, the providers can appeal to this. So it's not necessarily the end of the story. So they can revise and resubmit like we do for the journals. But this doesn't work all the time. So eventually, again, a significant chunk of the claim denials remain unpaid. Around 55%, there's an average of 55% success rate. And even if it's successful, this is actually a very costly and time-consuming process for the healthcare providers. And it creates delays in their cash flow revenue cycle that creates big challenges for hospitals that are in financial distress, especially serving in underserved areas. And these national averages coincide with the values that we heard from some healthcare professionals that we interviewed on this topic. So, for example, one of them mentioned that, so this is the Senior Director of Emergency Services at NYU Langone Health, that initial denials is between 9 and 14% of their net patient revenue, and the final denials is 2 to 6%. So a significant amount for them. And another professional mentioned that serving in a more underserved area, the time delay, right, that they have from the final decision is a really significant burden on them. So it takes about 6 to 8 weeks to get the final decision from the providers, and this creates delays in their revenue cycle. And when we ask about the role of information systems to these professionals in claims processing, they all talked about health IT interoperability and data exchange standards, that these are big challenges and burdens in this process, creating errors, right, creating these types of other administrative problems in the meantime. So we actually started with the idea of looking into the impacts of digitization and having these health IT technologies, but they actually guided us that this is more of an interoperability issue rather than just a digitization type of issue. That so we'll see that we explored this additional research question based on this idea. So claims processing is a complex task that is time-consuming and resource-consuming. Right, the claims put together a host of different types of information, medical conditions of the patients, different types of procedures, medications, right, they have coverages, right, all sorts of patient information. Collecting, organizing, reconciling all this information is a challenge for healthcare providers. And actually just 4%, 4 to 5% of their operating expenses goes to this collection process, a significant amount. And we started with the idea of looking at presence of electronic health records, how they can improve the claims processing, right? So these digital records. And overall, there's a big literature that I didn't cite here for brevity, right? We know that enterprise systems, also including in the healthcare domain, has been shown to improve data collection, data accuracy, right? More complete data than that can be used to justify eligibility, authorization, right? And reduce other types of errors, right? So overall, we would expect electronic health records to facilitate this compliance of the complex guidelines that healthcare providers have to deal with the insurance payers. And so this part is more straightforward and obvious. So in a way, we expect this type of digitization to be helpful for organizations to collect higher quality and more complete data about patients. So we wanted to explore a different aspect on top of this, and this is where our interviews have been very helpful, because the healthcare professionals that are working in this insurance claims processing domain have all talked about interoperability. So we went into this idea of exploring EHR sourcing, the vendor sourcing of different types of EHR applications. Because electronic health records, there are 5 major applications, right? So these are multi-application systems, right? They serve for different purposes. So some of them are kind of the backbone of the data repository. There are different types of systems for physician order entry and clinical documentation, right? So those are the systems that physicians are typing, as you see, right, when you go to a visit. There are also different types of decision support systems where combining the patient information with the past information, suggesting physicians for different types of treatments or tests that they might have missed. And so here we looked into EHR sourcing strategies, and we followed this paper on. There's not much literature on this topic, and but this is one of the papers that really dives into how EHR sourcing happens, and they basically analyze single sourcing versus multi-sourcing of electronic health record applications. And overall, right, the single sourcing can lead to better integration, right? Reduced department silos, reduced communication costs across different departments within the organization, more specialized knowledge of the IT staff because they have to deal with one single vendor. And an important part is also lowers the learning curve for physicians, nurses, the clinical staff that actually uses these systems. So if you talk to any physician or any clinician use electronic health record systems, they usually don't like them, right? Because they really have to do the burden of data entry. They think it takes time away from their interaction. So it is a difficult system to use from their perspective. So physicians have a lower learning curve when they're dealing with one single vendor, right? Because the interface and all these other functionalities are more similar. Right, so these are the benefits of single sourcing, but why some hospitals choose to multi-source. And in that case, right, there are some benefits to this as well, because they can select the best modules aligned with the needs of their specific departments. And this would eliminate or reduce at least to adjust their processes to some extent, right? And they will also have increased flexibility of changing their EHR applications among different vendors. And they will have a lower dependency on one single vendor, which can also have implications for the EHR vendor market competition. And when we look at the literature on the impacts of this EHR sourcing, there are a few papers looking into analyzing performance implications as well as impacts on care value and physician and clinician satisfaction. So overall, these few papers indicate that single sourcing overall is a beneficial thing for the hospitals, that the users have better satisfaction in using these multitude of systems, and it's found to be generally correlated with better financial performance. So we look into this effects of EHR sourcing on the claims, insurance claims denials. And also our contribution to this literature is we are looking at the network externalities, looking into the inter-hospital EHR vendor similarity for hospitals that are within the same system and that are sharing patient information and have a higher level of care coordination. And we also look at the physicians that work in multiple hospitals. So for the ones that might not be necessarily sharing information, but they have a common physician. So these physicians have to deal with different types of vendors and interfaces and see if that leads to any problems for these hospitals. And overall here again, right, with the benefits of single sourcing in terms of interoperability and data integration, we expect a higher level of single sourcing to be associated with fewer claim denials, right? Because information sharing and integration will be easier in this case. So overall, this is our expectation for within hospital, right? Within the same organization, if they have a higher level of single sourcing, we expect to see lower rate of claim denials. And similar idea for the inter-hospital EHR sourcing. So if a system of hospitals, group of hospitals that treat same patients, right, they have more compatible EHR vendors that increase, right, data exchange standards, improve integration, improve care coordination. We also, right, expect this to be associated with fewer claim denials. And again, another factor that can play a role in this inter-hospital EHR sourcing is the user experience, because it has been shown that physicians who deal with these different systems, they usually have lower satisfaction, and there can be some errors in data entry because they're not familiar with the system, etc. Right? So they have difficulty navigating these multiple layouts, functionalities, interfaces, and it could interrupt their workflow and lead to more informational errors. So for both of these reasons, data integration as well as users experience, we expect the level of EHR vendor similarity within the across group of hospitals in the same healthcare system to lead to fewer claim denials. Right, so that leads to our research questions. So we still first look into the effects of EHR adoption on claim denial rates. And then we go into, right, for this EHR adoption, the vendor sourcing decision within the hospital, across hospitals, as well as for physicians that work in multiple locations. We define them as peer hospitals and see what happens to their claims denial process. So to test these questions, we use data from state of Maryland. This is all outpatient claim records in Maryland between 2012 and 2016. And by Maryland law, all non-federal hospitals have to report this information. And here our unit of analysis is a claim. So we have about 19 million claims. And this is for about 3.7 million unique patients. So we can track patients over time across different locations. So data comes from 49 hospitals in Maryland. And we exclude patients who are not insured because they don't go through the regular process of claim right applications with the insurers. So this is about, I think, 4 to 5% of the total sample. So we drop the uninsured patients, and we have patients that are insured by Medicare, Medicaid, or a private health insurance company. And we control this factor because actually there is a host of papers looking into these claim denials and the claim processing across these different insurers. They all have different standards, right, regulations, coverages, and some of them are known to be more problematic or have higher denial rate than the others. So we control for this important factor. So this data has a unique patient identifier, which allows us to track the same person over time, right? So we can see different hospitals the patients visited and over different time periods. And as I will come to the empirical specifications soon, this allows us to control for these factors, right? Time, invariance, unobserved heterogeneity among patients, hospitals, and years. And for the health IT variables, we get the data from HIMSS analytics survey. So this is a very commonly used database to understand health IT adoption across hospitals in the US and Canada. And we have a measure of electronic health record adoption. So this will be kind of like a basic count out of the 5 systems, how many systems they have present. And we normalize it to be between 0 and 1. And for each of these 5 systems, we know the EHR vendor. So using this EHR vendor information, we calculate the sourcing similarity measures. So within hospital similarity measure, this is going to calculate the degree of single sourcing within the same organization, right? So here, if we have, for example, this is the sequence for the hospital, right? Out of the 5 systems, they have 2 of them are from vendor A, 1 of them is from vendor B, 1 of them is from vendor C, and 1 application is not adopted yet. And the single sourcing sequence for this hospital will be the dominant vendors, right? So if basically they need to move these 3 to A, right, to be able to be perfectly single source. So they have basically in this case 0.4 out of 5, right? 2 systems out of 5 that are single sourced. So a higher value will correspond to a higher level of single sourcing. And here we remove hospitals that adopted less than 2 applications, because we don't know, for them it's going to be hard to determine what their single sourcing sequence will look like in the future. And we also look at across hospitals, right? So for the inter-hospital similarity measure, we compare the focal hospital to its peers. And in this case, it's defined as the other hospitals in the same healthcare system, right? So these are from the same franchise, and they tend to, right, share a lot of patients together and coordinate care together. And here, right, if we have the example of the same focal hospital and another hospital in the system has a single sourced, right? So that's the sequence for one of them, and that's the sequence for another one. We basically look at the overlap of the focal hospital to each one of them. So the focal hospital with peer 1, they overlap 2 out of 5, right? For 2 systems out of 5 have the same vendor. And in this case, focal hospital with peer 2 coincides 4 systems out of 5. And they each get a score accordingly, and we average it out for the focal hospital. Okay. And in this case, we remove hospitals that have less than 2 hospital systems that have less than 2 hospitals. And finally, we look at a smaller subsample of physicians that simultaneously work across different locations in the same time period. And then we compare similarly their EHR vendor sourcing similarity. And in terms of the empirical specification, we have denied claims as the dependent variable. So this is a binary variable, whether the claim is denied or not, right? So this is a claim level analysis. And we look at electronic health record adoption, and later on, right, this sourcing similarity within and across hospitals for the past year. And we control for several factors that might impact whether claim is denied, right? So the insurance type, because it's important that some insurers are harder to deal with in terms of these submissions, and basically a host of measures to understand how complex that visit was. It was a revisit, right? Was it for a chronic condition? What was the total charge? How many procedures happened, etc.? Because all these factors, right, the complexity of the visit can significantly impact whether it's denied or not. And right, we control for time variance, patient characteristics such as age, and we can control for time invariant, unobserved heterogeneity among patients. So we observe the same patient over time, and we observe the same hospital over time. We also include year quarter fixed effects. Right, so there is always a bunch of endogeneity and identification problems in any empirical work. So because I don't have much time, so I'm just going to kind of list them here and go into the main results. But right, basically we do an IV analysis, matching analysis, including hospital-specific linear time trends, a Heckman selection model to trying to address all these potential endogeneity problems that we might have. But let me just jump into the results. So here, right, for the EHR adoption measure, so this is kind of the level of digitization, not without looking at the vendors. We find that, right, I'm not here presenting the control variables and all these other coefficients in the regressions, but we find a negative relationship between EHR adoption and claim denials. And as far as our main results go for the EHR sourcing similarity, so EHR single sourcing within the hospital and across the hospitals in the system, they both lead to a lower rate of claim denial. And to show one of the mechanisms here, we use a subsample of physicians. And these are physicians who work in multiple hospitals at the same time. So the first column is the physicians that work in multiple hospitals in the same quarter. So basically, they are working in these two locations, and we are comparing their EHR similarity, regardless of whether they're in the same healthcare system or not. And we find that the higher similarity leads to a lower claim denial. And in the second column, we actually extended to a year, right? Within the same year, do they work in different places, and what is the vendor similarity across these locations? And we can see, right, the results get weaker in this case, which makes sense because it shows there's a learning curve, right? Eventually, they are going to learn, even if 2 hospitals, 3 hospitals they work in have completely different systems, they're going to get adapted to this and they're going to learn. But at least in the short term, right, we see that this similarity has an impact. So I think the implication here that more training and support can be provided to the users, at least in the short term, for reducing the claim denials that is associated with these systems. And right, as always, you have to do a host of robustness checks to convince the reviewers, right? And in terms of the implications, let me just jump into this to end, and hopefully we'll have time for a few questions. But I think this shows the importance of interoperability and integration in this process. And there are multiple ways that can be achieved, right? We had some discussions on this, but better data standards and protocols, better regulatory support for this issue, education and training for users are important. And so these are, I think, some ideas that we haven't explored in this project, but I think they are important. They are likely important, right? The integration of the systems between the provider and the payer, and streamlining these changes in the payer requirements and contractual terms for the providers to be aware of these issues, again, are important parts of this process. So these could be, I think, good ideas for future research.